Hello, welcome to the virtual classroom. We're going to continue our lessons through video recordings and take home tests. So, where we left off was with client centered therapy, um, now, or person centered therapy. Person centered therapy um, involves several core principles of personality. The first is self theory, and that principle is that every person exists within an ever changing world in which the person is the center. So, if you've ever heard someone say, the world was created for my benefit, or I'm the center of the universe, well, in this theory, they might be right. We talked about phenomenology. Phenomenology is the value of the subjective experience. Uh, we talked about growth potential. Again, in this model, everybody has a desire to move towards self actualization. And we talked about conditions of worth. Conditions of worth is where your value or a sense of self is dependent on the standards that other people set for you. Usually, it's your parents, and if they hold you that you have to perform a certain way to be accepted, that would be conditions of worth. Naturally, conditions of worth are problematic. You want to have unconditional positive regard. Other things we talk about is where does psychopathology come from? And the basic principle is failure to learn from your experience. That is what causes psychopathology. So you might have heard the phrase insanity is doing the same thing over and over and over, expecting different results. Now, in this process, one of the things you want to do is create a safe experience for psychotherapy. Encourage the client to remain open so that they can see feedback and then eventually modify their behaviors, right? We talked about the conditions of worth. Another goal would be to maintain a sense of self that's not dependent on conditions of worth. They should have a stable sense of self. It should not be dependent on the day-to-day experiences. All right. So when we talk about relational conditions, there are three major relational conditions that we want to focus on. These are called the big three: congruence, unconditional positive regard, and empathy. I actually think we covered these, but I'm not sure. It's been a while between going down to DC and then putting a pause on our lessons. It's better to just do it again. So, for effective psychotherapy, according to Carl Rogers, you have to have two people making psychological contact. Long story short, the sufferer and the provider have to work together. The client starts out in a position of incongruence. They're vulnerable, they're anxious, they're operating from the position of conditions of worth. The therapist serves as a model of congruence. Eventually, they are wrapped into the relationship, positive relationship with the client. The therapist is also supposed to be providing unconditional positive regard. And in some ways, this is a reparenting strategy. The therapist is also supposed to be empathic and understanding. And ultimately, the empathy, I think I said, was the ability to put yourself in another person's position. And we did the role-playing exercise. But if you can demonstrate empathy and imagine what it might be like to be that person's going to blossom, that person's going to grow. All right. So, what was congruence? Congruence, by definition, is authenticity or genuineness. I describe this as being real. You want to be real with your clients, right? Rogers, here's some quotes from Rogers that highlights this. The more I can be genuine in a relationship, the more helpful it can be, right? So, who has a responsibility of being real? Most people think it's just on the client, but even the therapist has to be authentic. Another quote from Rogers is, "It is only by providing the genuine reality which is in me that the other person can successfully seek the reality in him or herself." That idea of the therapist has to be authentic, has to be genuine, is pretty profound. So long story short is, you have a responsibility, even as a therapist, to be real. I'll give you an example. With everything going on with coronavirus, we've moved towards telepsychotherapy, telemental health. And I was speaking with one of my clients yesterday, and her father was hospitalized and put in a CCU. They suspect he has coronavirus, and she wanted to go to work. And she is like, "I need to go to work. I can't not pay my bills." And one of the things about being real was for me to tell her what the concerns of that were, my experience with the concerns. And she didn't want to hear it, but I said, I'm not so sure that that's the safest thing, right? And letting her know, I hear her anxiety, I hear the stress about money, but I wouldn't be helping her if I didn't also talk about what I was experiencing from a real position, that she's putting people at risk. So long story short, I would have liked her to decide to just say, "You know what, you're right, Dr. Kaplan, I'm not going to work." In the end, that's not what happened. In the end, what happened was we agreed, because I was also hearing her anxiety and trying to be with her anxiety, that she would talk to her supervisor and let her supervisor decide. She is in a healthcare setting, but she's a medical assistant. But long story short is, she acknowledged that it would be taking the choice away from other people, so she would agree to at least talk to her supervisor. But it was hard for me to say that to her, because I know that she needed to go to work, but in a real moment, I couldn't not say it. Anyway, unconditional positive regard. So clients are valued and respected for who they are, as they are, with no strings attached. It's this radical acceptance that leads to self-acceptance. So if, again, because think about the logic, if the parents were putting conditions of worth and they were very hard on the kid's going to learn that they need to be a certain way to be accepted. But when the therapist is radically accepting, no matter what you say, I accept you for who you are, right? Eventually they learn that the roles that their parents played were not actually correct. And if I can accept you, eventually you learn self-acceptance. All right, so empathy. Again, empathy is absolutely essential. It's a prerequisite for many people for therapy. It's necessary. It depends on who you ask, but long story short, even though people knock client-centered therapy, what we tend to see is that it is an underpinning of all good therapy, whether Freudian therapy, whether it's behaviorism. It doesn't really matter, because what empathy does is it fosters a sense of compassion, and that will build a client-therapist bond. Empathy is multi-dimensional. Again, I love this quote. The most powerful thing from the client's point of view is to be deeply heard. In CBT, there is this idea where you want to challenge a person's thoughts, you want to reorganize their thoughts. From a Rogerian perspective, it's a non-directive therapy, right? So when you hear Natalie Rogers, right, say this quote, the most powerful thing from the client's point of view is to be deeply heard. It's true. It's true. It's absolutely essential. And maybe when you challenge a person, which is appropriate, it has to be after you have a sense of empathy and rapport built. All right. So there are different ways to view empathy. There's subjective empathy, objective empathy, and interpersonal empathy. So what is subjective empathy? It's identifying with the clients in the here and now, and then imagining what it must be like to be the client. Now, in the role play that we did in class, I discussed how sometimes you can't truly imagine, but imagine to the best of your ability. Interpersonal empathy is a two-way communication about the subjective experiences that the client is having, both with you and back and forth. And then there's an objective empathy, which is using theoretical knowledge and resources to help frame the client's experience or understand the client. So, what's the magic? What's the magic in person-centered listening? So, long story short, the magic of this model is that you create a safe space for a person. There is no real time crunch. I know with managed care or insurance, you're on the clock with psychotherapy, but from a person-centered perspective, you're not in a rush for these flashes of insight. All you're doing is creating a safe space for them to develop the insight and eventually move or grow. Another valuable thing in this model is to trust silence. For a new therapist, one of the biggest challenges that they will face is talking through the silence. Just because someone isn't saying something doesn't mean that they're not having an experience. So, long story short is sit with the silence. Allow the client to speak when they're ready, and don't try and direct the therapy because things went silent. Long story short, they know what they're experiencing. They know where they want to go next. Sit with the silence and do not talk over the silence. Now, also, the client knows where it hurts. So we might be an expert in therapy, but they're an expert on themselves. So we have to create an environment where they know that they can express whatever pain they're experiencing. So there are different approaches to person-centered therapy. The classical approach is what I've been describing largely. They uphold the 6 core conditions by Rogers. They say that these conditions are both necessary and sufficient. Now, it's interesting, both necessary and sufficient. That means that this is all you need, right? So when we talk about therapeutic techniques, if you adhere to those 6 core conditions, you should be fine. It's also non-directive, right? So we allow people to sit in the space that they're in without trying to have an agenda for them. And that's the classical person-centered therapy approach. Now, contemporary person-centered therapy, which I use some of this, it's a little bit more directed. So you're blending person-centered therapy with other approaches. We adopt the core three: genuineness, unconditional positive regard, and empathy, but we blend it with other approaches. So necessary but perhaps not sufficient is the contemporary approach. So I think we talked about this a little bit, but in assessment, let's just do it. Assessment issues. Classical PCT therapists, they don't use assessment or diagnosis. They don't think it's necessary. And in fact, it could potentially be problematic or detrimental. So you just focus on where the person is. There are people who are anti-psychiatry, the anti-psychiatry movement. They don't do some of the diagnostic work because they feel the labels are actually harmful. You do use diagnostic procedures to come up with a label, right? A label, those diagnoses, even though they don't adhere to them, they use it for insurance and billing purposes. But beyond the billing purposes, they don't use it. So, long story short, is that if 75% of people rely on their insurance provider to pay for therapy, they're going to want a diagnosis. So you give them a diagnosis, but beyond, for insurance purposes, you don't treat the person as the label, you don't treat them as the diagnosis. I think I might have said that you could have 30 people diagnosed with depression, and all 30 people, their experience would be different. From a contemporary approach, there is a little bit more of an assessment, emotion-focused therapy. That's some of the work of Sue Johnson. She's valuable to this field if you want to look up some of her work. But there is some assessment for that purpose. Okay. How do you lead therapy? Oh, 1 second. How do you lead therapy? This is allergies, I promise. You're going to start, you're saying, by you talk and I'll listen. I'll try my best to understand what you're experiencing. That's one of the ways to open a session so that the person knows that they're in the driver's seat. Rogers, in one of his books, he said, anything you'd like to tell me about yourself that will help me know you better, I'm happy to hear, right? So that's another non-judgmental, non-striving, non-directive way of asking people about themselves. I use this at the end of my clinical interview. Is there anything else you think I should know about you that we haven't covered? So this is pretty valuable. Now, allowing yourself to be congruent or being real, sometimes it's tricky. Sometimes you're going to have to censor yourself. Sometimes you're not going to share what you're feeling. In the case that I talked about, it was therapeutically appropriate for me to talk to my client about not going to work. But there are times when you will have to censor yourself. So being congruent, that doesn't mean that you say everything that comes to mind, because again, it's still supposed to be non-judgmental. If it's a bunch of criticism, then it can become judgmental. All right. So is it possible for therapists to try to feel unconditional positive regard towards their clients? Yeah, sure, right? Of course they can. I think that you want to be more passive or indirect in your communication so that it can be received. Very direct statements or criticism will oftentimes backfire, right? So communicating indirectly is helpful. Empathy, right? So person-centered therapists believe it's not possible for one to directly know another person's experience, but they try to do the best that they can. Now, I use a phrase for a person who is feeling suicidal ideations. I can't imagine what you must be going through because I've never been suicidal. But, you still try and do the best. So let's try and imagine what their home life or their personal experiences might be. Imagine what their feelings might be. Trying to do that to the best of your ability is important, and you want to express it to the client that you're feeling that. So that listening technique that was portrayed in the video with Summers Flanagan was essential. All right, so second generation person-centered therapy. We have motivational interviewing, emotion-focused therapy. We have play therapy. We have expressive arts therapy. There are many different applications. So, but motivational interviewing is one of the more common ones. And maybe I will, since we're going virtual, upload the video that you can see what motivational interviewing looks like. But it is the application. This is done by Bill Miller. Bill Miller was the creator of this. But it's very useful for people who get stuck. If you get stuck in your position, an example where it's commonly used is with substance use disorders. You use motivational interviewing to move a person along or help them grow. Now, with motivational interviewing, there are 4 core listening skills. The mnemonic is OR, right? So open-ended questions, affirmations or affirming, reflecting and summarizing. It sounds a lot like that active listening skill that Carl Rogers was talking about, right? So, but the nice thing about motivational interviewing is that you can take a person who's stuck, I guess that's the word I use, who has low motivation for change and get them to move along. So through these core listening skills, you can help people increase their motivation for change. So how do you combine the techniques? How do you get a person to change in light of person-centered therapy? Well, there are 4 overlapping components that motivational interviewing has with person-centered therapy. So collaboration. So when you think of person-centered therapy, it's a collaboration, it's a partnership. You're not striving with the person, you're not fighting with them. You have acceptance, which is unconditional positive regard. You have compassion, which is honoring what's in your client's best interest. And evocation, which is tapping into their wisdom. They're the expert in themselves. So you evoke is the root of the word. You evoke wisdom from them. All right. So you want to think of where they are. Again, I like to use a ruler or a spectrum and ask them to state on a scale of 1 to 10, how ready are you to make this change? And let's say they say a 3. I say, oh, wow, why not a 2, right? And what would it take for you to be a 4? So that's called a scaling question. But there are other techniques that are there. So you might have to listen for change talk and sustain talk. Change talk is talk that implies they're ready to grow, ready to move. Sustain talk is talk that um, means that they don't want, they're resistant to change. They don't want to move. So change talk is paying attention to the statements they say that implies readiness for change, and then sustain talk is where they're stuck. Reflections, there are different kind of reflections you could do. A simple reflection is just restating what they said, almost like a mirror. It shows that you understand what the client is experiencing. A complex reflection is a deeper level, more of the implication or the insight of what that might mean. Um, then you could mess around with it where you can amplify the reflection, um, where you intentionally overstate the client's point to the point where they're going to correct you so that they can recalibrate themselves. But it's done by design to get them to reorganize their thoughts or perspective. And then the other way you could do it is undershooting, is where you understate the client's point of view so that they can elaborate more. All right. So in terms of assessment, if you go by the classical traditional, they don't really use assessment. But in a more contemporary model, there are assessments related to self-esteem, interpersonal work. So you might see the Rosenberg self-esteem scale or inventory. You might see the 127 inventory of interpersonal problems. And then you might see the BDI, the Beck Depression Inventory. These are all measures of a person's psychological state that are used with person-centered therapists. When we talk about assessments, really, we do view Rogers as a scientist practitioner. He was interested in taking client-centered therapy and applying it to clinical situations. We talked about him as the first person to record his sessions, which opens itself up to research. Now, there are people who say that client-centered or person-centered therapy is a weaker model, but there's research, and I'm citing a couple studies that imply that there were no significant differences between CBT, psychoanalysis, person-centered therapy, and whatnot. We see in terms of clinical practice, it's a routine practice in the UK, and it works. You see the effect size, the Cohen's D of 1.2 relative to 0.24 for the control, so it is effective. And then when we talk about preventing depression, short-term or time-limited PCT is just as effective as cognitive behavioral therapy at treating depression. Now, in terms of cultural sensitivity, we always have to look at whether the model is sensitive. The focus on the self or self-actualization may not fit into collectivist worldviews where there's an emphasis on family or community at the expense of the self. So there is that concern. I have found, and this is anecdotal, so take it as you wish, that sometimes PCT is actually is helpful for the cultural experience, but maybe it's about how you do it. But your book says maybe you're not tapping into the cultural perspective as much. All right. Gender and sexuality issues, the feminist critique is advocacy. So if you're doing this in a non-striving way, if you're doing it in a way that doesn't push growth and advocacy, well, women have been subjected to persecution, and in a feminist perspective, self-advocacy is important, right? So waiting for the client to become ready is a problem, right? Um, Now, in terms of sexually diverse, transgender, or gender nonconforming client, it's very affirmative in its approach. So a person's sexual identity does not matter. We embrace a person and their perspective as they are. And then in terms of culture and language, it's also affirmative. Spirituality, again, when we talk about it, one of the perspectives about religion is that religion has a set of rules. And I think when we talked about Rogers, he grew up in a family that was very judgmental, very religious, and he himself went down that road, but he felt that religion provides conditions of worth. So that there is a challenge between the doctrine or dogma of religion and person-centered therapy. So he thought they were incompatible early in his practice. But as he got older, he had described some mystical or transcendental experiences which sort of reconciled some of this. So religion and spirituality do not have to be incompatible. Concluding remark is the therapist's empathy is the strongest predictor of positive outcomes. So the more empathic you can be, the better. And just to give you a take-home quote, the relationship which I found helpful is characterized by a sort of transparency on my part, in which my real feelings are evident by acceptance of this other person as a separate person with value in his own right, and by a deep empathic understanding which enables me to see his private world through his eyes. That is how you do it. So having empathy is going to help you grow. And that's the lecture. So I'm going to stop the lecture here, and we'll continue next class.